Catatonia is a severe neuropsychiatric disorder, but it's frequently underdiagnosed and undertreated. In these evidence-based consensus guidelines, I'll discuss the management of catatonia. These are based on the guidelines from the British Association for Psychopharmacology, and I've summarised some of the key recommendations in this presentation. A brief disclaimer, these slides are for educational purposes. They don't replace the BAP guidelines, which can be found at this link. They're freely available and open access. First of all, why do we need a BAP guideline on catatonia? Well, catatonia confers high morbidity and is associated with a longer length of hospital admission. And several studies, but not all, have suggested that it has higher mortality, even compared to other severe mental illnesses. It's a risk for numerous medical complications, such as deep vein thrombosis, pulmonary embolus, infections, severe pressure sores. And there's a risk of iatrogenic harm from inappropriate treatment of this condition. I'm going to summarise the BAP guidelines, which were developed by 22 experts spanning 3 continents and citing more than 500 articles. We'll have a look at the background to catatonia, how you go about assessing it, what the treatment options are, and then we'll look at a few subtypes of catatonia and related conditions before considering how the guidelines apply to special groups. And we'll round off with a few key points. So, catatonia. Catatonia is a severe neuropsychiatric disorder. It affects movement, speech, and complex behaviour, and often there's some involvement of the autonomic nervous system and some affective disturbance. For example, patients often exhibit fear, and there's sometimes tachycardia and other signs of sympathetic overactivity in catatonia. In terms of the diagnosis, the Diagnostic and Statistical Manual of the American Psychiatric Association and the International Classification of Diseases have converged on a consensus that you need at least 3 catatonic signs necessary for the diagnosis of catatonia. And examining the evidence, we felt that this was reasonable. There are many signs of catatonia, more than 50, but some of the more specific ones that are included in diagnostic criteria are these ones here. So agitation that's completely out of proportion to any external stimulus, ambitendency, which is hesitant oscillatory movements, catalepsy, which is an induced movement disorder where an examiner elevates a limb and a patient holds it in that position against gravity, echolalia, repeating back an examiner's speech, echopraxia, mimicking an examiner's movement, grimacing, mannerisms, which are abnormal movements that are complex and inappropriate to the context, mutism, the absence or almost complete absence of speech, negativism, the seemingly involuntary action of not following instructions or doing the opposite of those instructions, posturing, which is spontaneously putting a body limb in a particular position and holding it against gravity, rigidity, staring, stereotypy, which is repetitive complex movements that are purposeless, stupor, a reduced state of responsiveness to the external environment, verbigeration, which is a repetitive speech, a little bit like a scratch record, and waxy flexibility, which is sometimes defined as a slight and even resistance to movement, and sometimes as an initial resistance to movement, to passive movement, followed by a loss of that resistance. It's worth noting the categories of evidence that we used for this guideline. You can see here that there are categories for causal relationships and treatment, which starts with randomized controlled trials and goes down to expert committee reports going via more observational studies. And similarly, there are categories of evidence for non-causal relationships. Based on these categories of evidence, we used a 5-part classification of the strength of recommendations. So category 1 would be directly based on category A would be directly based on category 1 evidence, so this RCT data, B based on category 2, and all the way down to S derived from a consensus view in the absence of systematic evidence. It's worth saying from the outset that sadly there's a dearth of good evidence in catatonia and a lack of the important research we need. So there were no category A recommendations. There are a few category B recommendations, but most of them fell into the C and D categories with some S category recommendations. So, how do you assess catatonia? Well, first of all, it's worth thinking about the various conditions that might underlie catatonia. Catatonia rarely arises on its own. The majority of cases of catatonia overall are associated with a psychiatric condition, but the particular prevalence that an individual clinician is likely to see varies depending on the scope of practice. So within medical or neurological settings, there's much more likely to be some of these conditions that might account for, say, 50% of catatonia cases, compared to in a psychiatric setting where some of these conditions are more likely to predominate. Some important ones to highlight are central nervous system autoimmunity and inflammation, particularly autoimmune encephalitis, and especially NMDA receptor encephalitis. Central nervous system infections such as HIV, syphilis, and herpes simplex virus, some endocrine disorders, some focal CNS lesions, but they don't seem to be localized to any particular part of the brain. Some medication and administration and withdrawal syndromes, some metabolic disorders, some neurodegenerative disorders. Occasionally, catatonia can be a presentation of non-convulsive status epilepticus, and there have been occasional reports of toxins associated with catatonia. In terms of the psychiatric disorders, the most prevalent causes of catatonia are actually mood disorders rather than psychotic disorders. So particularly, notably major depressive disorder and bipolar affective disorder. There's an interesting relationship with autism spectrum disorder, in which catatonia is substantially overrepresented. And catatonia can, of course, appear in schizophrenia and other psychotic disorders, as well as some other psychiatric disorders. When taking a history from an individual with catatonia, it's important to bear in mind some of these possible etiologies. So consider whether the individual or a family member has any other major psychiatric disorder, any neurodevelopmental disorders such as autism. And it's worth considering whether they have any neurological or other medical conditions, particularly those that have been associated with catatonia, such as encephalitis, lupus, or epilepsy. In terms of the detailed history from the individual, when catatonia arises acutely, it's not uncommon to find that the addition or the subtraction of a medication has been very closely temporally related with the onset of catatonia. So a careful medication history is really important. That should include psychotropic drugs, but also any other medications that the patient is taking. Consider as well recreational drugs, such as cannabinoids and stimulants, and consider exposures which might be risk factors for HIV and syphilis, such as their sexual history and any intravenous drug use. In terms of physical examination, there's quite a lot to consider in a patient with catatonia. But some of the most basics are the most important. So considering their volume status, do they show signs of dehydration or malnutrition? Patients with catatonia have been known to develop acute kidney injury and become severely malnourished due to poor oral intake. Do they have a temperature? If you're considering electroconvulsive therapy or ECT, you need to perform a cardiovascular examination to ensure that they're safe for that. Examining a patient's respiratory status is important if you're considering benzodiazepine administration. As we'll discuss later on, benzodiazepines are sometimes used at quite high doses in catatonia. It's worth performing a neurological examination to assess for any localizing signs that might point to a focal neurological origin of catatonia. And it's worth looking for complications of catatonia as well, such as pneumonia in the respiratory examination, deep vein thrombosis when examining the lower limbs, and any pressure sores. In terms of the assessment of catatonia, there are a number of assessment tools out there. The ones we recommend for adults are the Busch-Francis Catatonia Rating Scale and the Nordhoff Catatonia Rating Scale. They only take 5 to 10 minutes. The Busch-Francis has the advantage of having this excellent training manual available online, which you can find at this link here. And this has got videos as well as step-by-step instructions of how to conduct the examination. For children, a few adaptations are worth considering, and the pediatric catatonia scale is basically a slight revision of the Busch-Francis modified for the needs of children. When investigating a patient with catatonia, there's no one-size-fits-all. So sometimes after a careful history and examination, the underlying etiology of the catatonia becomes very clear. And there sometimes the investigation needs to be a lot less extensive than in the more complex cases where you're really unsure as to the underlying etiology. The latter are not uncommon, given that history from the patient with catatonia can sometimes be extremely limited. So, some things to consider. Blood tests. So these might be infection markers. These might be markers of renal and hepatic function based on the treatments that you might give a patient. They might be inflammatory markers. A urine drug screen, a lumbar puncture, an electroencephalogram, and neuroimaging, CT or MRI. We do make a couple of specific recommendations though. The first is that if this is the first episode of catatonia or the underlying diagnosis is unclear, consider neuroimaging in the form of CT MRI and autoantibodies. Now, NMDA receptor encephalitis, as I mentioned, has been strongly associated with catatonia. About 80% of patients with NMDA receptor encephalitis have catatonia. And so that's one antibody you definitely want to check for in serum and CSF. But there are various other antibodies that are associated in case reports with catatonia. And depending on your index of suspicion, you might want to test for those as well. Particularly if you're conducting a lumbar puncture and you want to make the most of that. The second quite specific recommendation we make in terms of investigations is that if there are any risk factors for seizures or any possible evidence of a seizure, or it looks a little bit like encephalitis, you really don't want to miss non-convulsive status epilepticus presenting as catatonia. So consider an EEG, and you want to have continuous monitoring with video telemetry if possible. One of the most useful investigations for identifying catatonia is the Lorazepam challenge. And I'm just going to take a quick diversion here to talk about how you might go about that. First of all, you assess baseline catatonic features using standardized instruments such as the Busch-Francis Catatonia Rating Scale to give you a baseline idea before you administer anything. You then administer a dose of Lorazepam, ideally intravenously or intramuscularly, as it tends to produce a more rapid and more pronounced effect but you can also administer lorazepam orally. After that, you reassess catatonic features. You should see some effect within 5 minutes if giving IV lorazepam, 15 minutes with intramuscular dosing, and within half an hour with oral dosing. And then when you reassess, you repeat your Bush-Francis catatonia rating scale, and a positive response is considered to be a 50% reduction in the score. This is helpful for a couple of reasons. Firstly, it helps you in identifying catatonia if that happens. And secondly, it suggests that this person is likely to respond to further doses of lorazepam in the future. If you don't get a positive response at step 3, you can consider a further challenge and repeat steps 2 and 3. The differential diagnosis of catatonia is very wide, and there's a subtle distinction here between the disorders that might underlie catatonia, if catatonia is identified, and the disorders that might look a little bit like catatonia but are not catatonia. And we're thinking about that second category here, although with some of these there is a little bit of overlap and some debate. So, first of all, neurological movement disorders. Think about Parkinsonian disorders, extrapyramidal side effects of antipsychotic medications, serotonin syndrome and neuroleptic malignant syndrome, which we'll talk about in a minute. Stiff person syndrome is an interesting but rare neurological condition associated with rigidity, muscle spasms, and sometimes severe anxiety as well. So these patients often end up going through psychiatric services first. In terms of speech disorders, it can be helpful to try to look for the non-speech features, and with, say, anarthria and selective mutism to try to get the patient to write rather than speaking, to try to distinguish catatonia from these speech disorders. As I mentioned, non-convulsive status epilepticus can look a lot like catatonia and can in fact present with catatonia. Locked-in syndrome and disorders of consciousness can look very similar, and in clinical practice I find that hypoactive delirium is one of the biggest differentials for catatonia. Disorders of motivation are behavioral neurology conditions where patients seem to have a buoy or this complete lack of motivation. And there are various psychiatric disorders that can look like catatonia as well. Mania can be hard to distinguish from an excited catatonia presentation. Functional neurological disorder, often there's a focal element to them in a way that there isn't with catatonia, which will tend to affect the whole body. Autism spectrum disorder, there's some overlap in terms of stereotypies, mannerisms, even mutism. And sometimes in clinical practice, it can be hard to distinguish catatonia from malingering and fictitious disorder. Inconsistency in presentation can be helpful to some extent, although catatonia can wax and wane. So that's the assessment of catatonia. Let's move on to talk about its treatment now. Probably the most important point is that you need to start treatment promptly. There have been several studies associating delayed treatment with poorer treatment response. Now we do by and large have good treatments for catatonia, but delaying treatment seems to be associated with those treatments being less effective. In terms of the treatment, it's very simple really. There are 3 things you need to bear in mind. First of all, specific treatment for the catatonia. Secondly, treatment for the underlying condition, whether that is a psychiatric disorder that might need an antidepressant, say, or a neurological condition that might require immunosuppression or antibiotics. So that's number 2. And thirdly, there's prevention and or treatment of the complications of catatonia. We've mentioned deep vein thrombosis, pulmonary embolus, acute kidney injury, malnutrition, dehydration, just a few. In terms of the specific treatment for catatonia, the first line treatment should be benzodiazepines and or electroconvulsive therapy, ECT. When deciding which of these to use, sometimes the decision is very straightforward. For example, in a case where one of these is contraindicated. But sometimes either one could be used, and we suggest that you consider the side effect profile for the individual, whether an underlying condition might respond to ECT. So, for example, if you have a patient with catatonia secondary to profound depression, the depression is likely to respond to ECT as well as the catatonia, so ECT may be a better option there. And finally, local availability. Sadly, ECT is not always available. Let's go into a little bit more detail about the use of benzodiazepines for catatonia. There isn't a huge amount of evidence distinguishing one benzodiazepine from another, and in fact, there's evidence suggesting that most of them seem to work. However, there's most clinical experience with Lorazepam, and there are a few nuances to bear in mind with Lorazepam where we just don't know about whether it applies with other benzodiazepines. So we suggest that Lorazepam should be the first option. One interesting thing about catatonia is that patients with catatonia often tolerate and require very high doses of benzodiazepines. Some respond to fairly moderate doses, such as 2 to 4 milligrams per day, but others require much higher doses. And we suggest that before a trial of Lorazepam is considered to be sufficient, the dose should have reached at least 16 milligrams per day, or the catatonia is adequately treated, or the side effects prevent further titration, and this tends to be sedation, although obviously respiratory depression is another important side effect to look out for. Obviously, you don't start at a low dose at a high dose of Lorazepam. You titrate up gradually. You should reassess symptoms and side effects frequently. Once catatonia is successfully treated, or you decide to stop the Lorazepam regardless, it's really important not to stop suddenly. This is A, because catatonia can rebound if this happens, but B, because you can have withdrawal symptoms from the benzodiazepines, and including occasionally seizures. Electroconvulsive therapy is also highly effective in catatonia. There's a little bit more evidence for bilateral ECT, and that's what we suggest. There are reports of ECT being given 3, 4, 5 times a week for catatonia, even more than once a day. We suggest that ECT should be given at a minimum twice weekly. In terms of the number of sessions, there's perhaps more of an art than a science to this, and it depends very much on how a patient is doing in terms of their treatment response and the side effects after each dose. This can be dynamic and re-evaluated throughout the course of treatment. In the catatonia literature, there are numerous case reports detailing a wide variety of medications and their effect on catatonia. There's increasing evidence for the NMDA receptor uncompetitive antagonists, amantadine and memantine. And because of this, we suggest that if the first-line therapies, that is benzodiazepines and ECT, are not effective or are contraindicated for some reason or only partially effective, the drugs, one of these drugs, amantadine or memantine, should be tried. One of the debates in the catatonia literature is about the use of antipsychotic medications or dopamine 2, D2 receptor antagonists. The debate is because, on the one hand, the underlying disorder for catatonia may be a psychotic disorder that intuitively you think need treatment with a D2 receptor antagonist. On the other hand, catatonia is a strong risk factor for neuroleptic malignant syndrome. What we suggest is that where there's no underlying psychotic disorder, we do not recommend the use of antipsychotic medications. There doesn't seem to be a rationale for their use there, and you're facing various risks. There is such a thing as antipsychotic-induced catatonia, so it's possible that antipsychotics may in general worsen catatonia, but we don't have high-quality evidence for that. Even in a psychotic disorder, if you do choose to use antipsychotics, do it with caution, as they may worsen the catatonia and they can trigger neuroleptic malignant syndrome. Okay, so that's catatonia as a whole in a nutshell. Let's have a look at some subtypes of catatonia and related conditions now. First of all, periodic catatonia. This tends to be characterized by rapid onset, brief, recurring episodes of catatonia. The episodes tend to last only a few days, but the remission period can be between weeks and years. It seems like, although the evidence is not terribly strong, mainly case reports and series, that benzodiazepines and ECT work well acutely. But the clinical question often is, if someone's having multiple of these episodes, and they can be extremely impairing and debilitating, how do you prevent these episodes? And there's some case report evidence suggesting that prophylactic lithium may be useful here. Malignant catatonia. Malignant catatonia is where there's catatonia plus an increased temperature and autonomic dysfunction. The treatment here is to stop all dopamine antagonists, which seem to make this condition worse. Trial of Lorazepam and electroconvulsive therapy. Neuroleptic malignant syndrome is sometimes considered to be an antipsychotic-induced form of malignant catatonia. It's certainly associated with a high mortality. In terms of the treatment, first of all, it's really important to stop all dopamine antagonists, as well as anticholinergic drugs. Supportive medical care, often in an intensive care unit, is necessary. In milder cases, consider benzodiazepines. In more severe cases, consider a dopamine agonist such as bromocriptine. Consider amantadine, dantrolene, and electroconvulsive therapy, ECT. Antipsychotic-induced catatonia. Well, the obvious treatment here is to stop the antipsychotic. Sometimes, however, a benzodiazepine may be used as well. What about special groups? How much do these guidelines apply to certain subpopulations? Children and adolescents. We've mentioned use of the pediatric catatonia rating scale. Catatonia has actually been reported in children as young as 5, though it seems to be rarer than it is in adults. It's worth noting that quite a lot of cases of pediatric NMDA receptor encephalitis have been reported in association with catatonia, so this is an important diagnosis to have on your radar. But otherwise, the management is more or less the same as in adults. Among the elderly, catatonia can easily be misdiagnosed as delirium, stroke, dementia, or coma. And this is really important because there have been cases where care has been withdrawn from an individual with catatonia on the assumption, say, that they have had a stroke or have advanced dementia that is incompatible with life in the coming weeks, for example. However, catatonia, of course, is eminently treatable in the majority of cases. It's really critical to identify it in these individuals. Elderly people, of course, are at greater risk of most medical disorders, so look carefully for them. Dosing of benzodiazepines does need to be much more careful and much doses in the elderly. What about the perinatal period? Well, the overriding principle here is to weigh the risks of treatment and no treatment to the mother and the baby. If specific treatment for catatonia is required during pregnancy, there is an absence of data on the safety of benzodiazepines beyond the doses that are licensed for other conditions. So for a number of conditions, Lorazepam is licensed at 4 milligrams per day. We don't know the safety going beyond those kinds of doses. So we suggest using those fairly moderate doses to start with. If that's not effective during pregnancy, we suggest going straight to electroconvulsive therapy. Postnatally, if Lorazepam is going to be used at higher doses than 4 milligrams, again, we just don't know about the safety of breastfeeding with those kind of doses. So we suggest that the mother doesn't breastfeed if on those high doses of Lorazepam. In terms of autism spectrum disorder, catatonia is quite common in ASD, so it's worth being vigilant. However, there's some nuance here in that there's substantial overlap between the features of ASD and the features of catatonia. And some of these features may be very long-standing in ASD, such as posturing, echolalia, stereotypies. So we suggest that to avoid overdiagnosis of catatonia, if you're going to diagnose catatonia, there needs to be some marked change from baseline. In mild catatonia, we suggest using specifically designed psychological interventions, which are largely behavioural and involve a structured routine and behavioural cues or prompting during episodes of freezing and or Lorazepam. In moderate or severe cases of catatonia, we suggest following the normal treatment algorithm. In terms of medical conditions, there are issues in terms of drug metabolism. In renal impairment, you don't usually need to alter the Lorazepam dose, but do monitor carefully. In severe hepatic impairment, do be cautious with Lorazepam use. In severe respiratory disease, consider ECT as first line rather than benzodiazepines. So, some take-home messages. Diagnose catatonia on the basis of 3 or more signs in DSM-5, TR or ICD-11. If you're in doubt as to whether you have catatonia, as to whether a patient has catatonia, use a Lorazepam challenge. There's a really wide range of medical, particularly neurological conditions and psychiatric conditions that can underlie catatonia. The investigations you should use vary according to the clinical picture and your index of suspicion. First-line treatment is Lorazepam, sometimes at high doses, and or ECT. Thank you very much for watching this video. If you'd like more information, the guideline can be found at the link on this slide, or I'll paste it in the video description. I'd like to thank very much the other authors of the guideline as well. Thank you very much.